So, hello and good morning. As we had this very good case for demonstration, we are going live. This is a case of, you can see, our favorite disease, which is not very much good and favorite for the patient, but fine. So this is momentum, which is adherent. So basically, she is a case for TLH, and she has got endometriosis, where there is you can see the chocolate cyst from this side. She has got previous C-section, so bladder is adherent. This peritoneum, you can see the momentum, which is adherent there, and we will go with our standard protocols and tips and tricks, right? So first we'll go for radiolysis. Let's see, all this momentum is adherent, so we are going to separate. That is one. We know that it is momentum and which is adherent from this side, so we'll be little bit careful because we don't know what is lying just below this momentum, fine, where it is adherent. So what we usually recommend, or what we usually do, is to go very gentle. Can you see this? See this? So that's why I'm saying you never know what is lying there. It may be ovary, maybe uterus. चल पकड़ जाने. Here this is serosa. Can you see serosa? Okay. So gentle, be very much careful. Energy source, though in watch please, though in endometriosis it is advisable to use energy source as much as possible to decrease bleeding, fine, but then uh, there is something called as judicious use of energy source. So if you are not sure about structure, better not to use it, fine, better to go with blunt dissection. Problem is, I'll tell you what problem is. Can you see this serosa, and can you see the color of this fibroid or uterus, or it is same, more or less same? So many a times you will not be able to identify exactly that what is it. Okay. And by the time you realize that this is bowel loop, can you see this? You may end up doing some injury. Fine. So that's why in such cases, unless and until you are 100% sure, it is advisable not to use energy source. Fine. Yeah. So now you can see here, that's the again peritoneum, which is adherent. એટલું અટરાક્યું છે. તારે થોડુંક દિમાગ લગાવવાનું હો ભાઈ. Fine. Now it got sorted. Now we will touch base. Active jaw, I'll keep under my vision. Fine. Now this is a right side. This is left side. Definitely we'll have to rupture this, otherwise we'll not get proper plane or space inside. This is femoral end. This. Watch please. Fimbria is highly vascular thing. If you touch, it will start bleeding. Fine. Yeah, Jal. આ બાજુ. Now, if we follow uh, our standard protocol, that's the sigmoid colon mobilization, or the point of view of adhesiolysis from this area, as we are going for TLH and BSO. So Madam Osaji, fine. Now, if we want some dissection in this area, we should be oh, chalo, put it in suction. Suction, pressure, fine. So uh, the cyst was suctioned out. Now we can, now see, we can do few things. Now we need to decide if it is BSO, and if we are going to take this out, then it is always better to go into retroperitoneum, fine, to find a proper space, because retroperitoneum is empty. See, this part is empty. Okay. So if you want to preserve that particular area, then it is better that you do dissection in the medial aspect. But then for ureterolysis, it is advisable that if you find ureter, okay, with the medial approach, that means from here. Medial means from here. Okay, lateral means you go in the retroperitoneum and find the ureter. Okay, so if you uh, find ureter from the medial approach, it is better. Better because after ureterolysis, what is our next step in such kind of, yes, pararectal space dissection. So for pararectal, if you are are doing or going for the ureterolysis with medial approach, parietal space dissection would be easier. Okay. હવે છે ને મને અહીંયાથી યુરેટ્રોલાઇસિસ કરાવો એટલે એના માટે તમને એક્સ્ટ્રા ટોકર હા નાખી શકાય, નાખી દેવું પડે. લાઈટ આપો જરાક. ઓપ્સ. ગ્રાસ પર so yeah, so here what we will or we are planning to do is ureterolysis from this side. Now we are lifting the peritoneum up. પકડો. Now we are entering inside the this peritoneum. You have to remain superficial. Okay. Let me be sure that this is ureter. Watch this up. Hello, you need to be sure that that's the ureter, and you can be sure only with peristalsis. Okay. So let us see peristalsis. Okay, fine. So that means we are in the correct area and correct plane. That's the ureter which is going down and down. See, my entire instrument can reach up till the, I think, ureteric tunnel also I can reach. Fine. Now what I'm going to do is, I know that this is the ureter. Watch this. So I'm going to dissect this. And prepare myself for the next stage of dissection. It is not very dense, but then it is very badly adherent. Chalo suction. This you should only be doing if you have very good idea about the ureter. Okay. Otherwise, you should not be doing it blindly. So where is ureter? It is here. We know that ureter is here. That's why we can go into all these spaces without વાંધો નહીં અને હવે અમે કાઢી લેવાનું થશે મને અહીંયાથી હવે so suction is very important tool, huh? There are so many by clean. There are so many spaces or places where you have to use only suction because you cannot continuously use a gauge piece, mop it, and then again you go for dissection. This may not be possible always. So there are so many places where you have to use suction, and it's very good. This entire area we will have to take out, huh? Fine. Now I'm going to retroperitoneum up with the gospel. સાઈડમાં રાખજે મિથુનભાઈ બાજુ ને નીચે યુટ્રસ તારો. So now this is a see round ligament. Okay. So we'll cut open round ligament. Still we are lifting it up. This is IP. Should be careful little bit as now there will be. Now second point is looking at this tissue and this texture, you definitely will find fat tissue inside the retroperitoneum and which will bleed. Can you see this? This, okay. So that should not mm, create problem. So for that, what you do is you follow your standard, steps. You can see this is lymph node. Can you see this? Okay, that is usually reactive lymph node, and it is of no, problem. But then you should have idea about it. That's the external iliac vein. That's the internal iliac vein. Sorry, artery. Suction. That's uterine. Obliterated umbilical ligament. This. Okay. And now there will be ureter, which I guess will be just near the uterine. Grasper. Mm-hmm. Acha ureter. That's the obliterated umbilical. Okay. Chalo. Chalo. This is ureter. Bipolar दीजिए. I know ureter is down there. That's why I can directly go and coagulate. If you don't have idea about the ureter, please do not directly go and coagulate. First you identify ureter, and then in case if what I did is window in posteriorly for broad ligament. Okay. In case if you don't have window and you don't have idea about ureter, directly do not jump on coagulating IP ligament. Fine. First you find ureter where exactly it is located, and then you can tilu chhod do. Fine. Now you can see ureter which is going down from here. With this. Okay. So ureter is very close in this area. There are high chances of ureteric injury without dissection. If you do it without dissection, चिपा छोड़ ले ऊपर से बोला गया. चलो. જોઈએ. अब देखो. चलिए मैं कुछ भी सब. You can, but then care is, always you will have to remain away. That margin or distance you have to maintain. Short burst of energy. You should not be keeping your energy source activated for longer time. There are so many aspects which you need to. Same thing applies to ultrasonic energy as well, but then little bit of liberty you have with ultrasonic as the spread is comparatively less. But then that does not mean that you will keep it activated for longer time. Niche rakh. So no energy source should be kept activated for longer time. That's the key in gas निकले थे. In such kind of dissection. Fine. So in adnexa removal in this kind of cases or in cases where it is very difficult or adherent, a rule what we follow is number one, sorry, you should be rule basically what I follow. I don't know maybe what others they are doing, but then rule what I follow is you go for dissection circumferentially. Okay. So you little bit of dissection from here, then you have some issue because you are going to, down near the rectum or the ureter. So you go into the retroperitoneum, that is opposite side. Okay, then you come down from here, then you dissect from the upper side. So what I prefer doing is I go circumferentially. Okay, so all around. So what benefit I get is I'm able to dissect from everywhere, detach few areas where it is attached, and it gives me more mobility to the specimen. Okay, so my specimen is more mobile for dissection. Right. Before that, definitely I would go for the ureterolysis, and we know right now what is the exact location of the ureter. Right. Over. Suction. So this mass is adherent, fine, and ureter is going just from the area where this mass is adherent. That means the ureter is this. And that's why we need to take care of the ureter as much as possible. This is ureter going down. See this peristalsis from here. Okay. Okay. Hmm. You can, you know, you can looking at this tissue structure, you can have idea about the dysmenorrhea which patient was having. Amount of adhesion और आने एक मिनट The first look, it seems ureter is engulfed. चलो. See ureter now? Here. Okay. So now it is completely out. चलो आ बाजू ले, तुम्हारी बाजू ले. Yes. नीचे रखो. अजी नीचे रखो. तो ना. She is case of previous C-section also, huh? That you have to remember. चलो बाजू पाड़ो. મૂકી દે, બધું મૂકી દે, વાંધો નહીં. चलो मुझे बाइपोलर चाहिए. Fine, we can go now anywhere we want because we know that ureter is going from here. See this ureter? So now we can go to this area for the adnexa removal. Adnexa removal is the key part of doing TLH in such kind of cases because if you remove adnexa, specifically this kind of adnexa where some you know sort of cyst was there and it is very space occupying you know thing, it will give you advantage of it will give you advantage of see now vision. Now your vision is clear. Anti track beta. Okay, so it is uh, still दिल्ली दूर है, but then fine. अभी मैडम इसको भी क्लियर करना है and હવે ગોચ પીસ છે બીજું. हाँ अंदर अंदर एनाથી क्लीन करो. नहीं नहीं आप इसको बस एक बार क्लीन कर देना. हाँ तो એનાથી ઓલી સાઈડ જરા ક્લીન કરો. ના ના યુરેટર આપણે જે કર્યું ને એ બાજુ મૂકી દો ત્યાં ને ત્યાં ક્લીન કરો. એક વોચ પીસ હજી નાખું છું અંદર. और इसको भी now after removal of that adnexa, we have got two options. Either we can go with the continue with our dissection and go with the pararectal space dissection from this side, okay, or we can go to opposite side, and from opposite side we can start from ureterolysis and go ahead, okay. What we will prefer is going into pararectal space dissection from left side because dissection ureter is in front of us, and we'll finish with one side and then we'll come go to the opposite side, okay. Fine, 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 चलेगा ना. So now for the pararectal space, you first have to decide the exact area where you want to be. Okay. Now this is ureter. Keep in your mind. We want to be just lateral and parallel to the fat. So you can see this is a peritoneum. This is a yellow fat. Can you see? Actually, this entire fat is not very. मुझे this entire fat and tissue एक मिनट हो. This entire area which is involved, I am going to take it off. Very tough, huh? अरे हम होंगे अल्लाह मुझे. So for doing all these things, first you should have exact idea about the anatomy. Second, vital. Now can you see this? Chalo. show you one more important thing. Have you guessed it now? Fine. હા, હજી આપણે પેરારેક્ટલ પ્રોપર ડિસાઇડ નથી કર્યો, મને ગોચવી આપો. That whatever we have removed was the superficial thickened layer of peritoneum. Still we are यहाँ पर तो bleeding क्या था? ये ठीक है क्या? कुछ भी सब तो बायप्रो रेडी करिएगा मैडम. Always remember safety is first priority. Huh? So doesn't matter if it takes time, if it is difficult, or whatever it may be. चलो मुझे लगे तुम पकड़ गए क्या अभी? पकड़. So whatever it may be, but then safety is the चलिए मैडम first priority. Yes, truth. And in such cases, you can see that planes are lost. Okay, lost means it is not very easy to find plane. Usually, what happens in pararectal space and all, you go in, you just remain lateral to the fat, and usually you can easily find the plane. Right? हमारा बे instrument occupied છે નજીકા ભાઈ. So this is fat. Okay, I'm remaining just away from the fat for this dissection. I'm very gentle because whenever you are working near the fat, high chances of bleeding whenever there is a fat. Okay, because fat omentum they are having very good blood supply. Chalo. Hmm. They have very good blood supply. Okay. So now that's exact pararectal space, right? Sorry. Hmm. Chalo. Let us see. Chalo opposite. Now we are now we are going to perform, or at least we'll try our best to perform same things on this side as well. Right from the ureterolysis, અમુક લેવલ સુધી થશે ભાઈ, થશે નહીં. મૂકી દો. નીચે રાખતો ભાઈ ને મારી બાજુ રાખ હવે. So now what we are going to do is dissection of retroperitoneum. ભાઈ તો આમ જ બતાડીશ, તમારે કેમ જોવાનું પછી? That's the round ligament. કોચ પૈસા બોલો. Fine. So going into retroperitoneum, our aim right now is to find ureter and the other and other vital can you say ureter? This is ureter. That's the internal iliac, and the bluish color is the uterine. એક મિનિટ ઉપર ક્યાંથી આવે છે bleeding? See, that's the ureter. નહીં સરખું બતાવો. Fine. Bible. So pressure at the origin of uterine from internal iliac is quite high. Fine. So, so if you want to dissect it, what mistake I did was I started with the first chunk from here. Okay. So definitely cutting is has to be little bit away from the origin. That means not from here, but from here. But then pressure at that particular level is quite high. So you need to remain little away from the origin, from internal iliac, right? Hmm. That's ureter, which is going in from here. And बस यहाँ थे फिल डालते हैं just जी बराबर से आप now from this side, right? चलो हम now what is my purpose is to detach. As I said, I always go circumferentially, so detach from this side as well. This side should not be a major issue because we will remain superficially, and we know exact right now we know exact position of the ureter. Okay, so dissection in this area should not be the problem. But at the same time, we should not be aggressively going in from this area without oops. Shall we? Now, since it got ruptured, it is good for us because now we'll get a proper space for dissection. Second important thing which I want to share is now you are at this stage. Okay. So please do not try to forcefully detach it from its attachment. See, this is attached. Don't try to give traction or do not try to take it out forcefully. Okay. Always superficially, but then always chalo, use energy source. Okay. What happens? Bleeding will be less. If you will try to take it out forcefully, there will be more bleeding. So, engineer nothing. Okay. So this thing is done. Now this is ureter. If you want to confirm, Olibajab, you should confirm that this is ureter. Fine. Once it is confirmed, you can extend this window. This is ureter now. Okay. So you can yeah, so you can extend now this window. That is for the safety of the ureter. Fine. Bipolar. still I'll not remain here. Okay, from origin, because you know that IP is the direct branch of abdominal aorta. Fine, Tilu, and no bleeding. So now we'll go to niche raak, side में raak हमारी बाजू. Again we'll go for the adenexa, complete adenexa removal from the right side as well. Now we can easily go because we know that everything is detached and ureter and all is away from our area of dissection. So the baseline is, in any case, the either, if you are talking about conservative surgery, then adnexa should be lifted and uh, uh, tied or hanged, attached with the lateral pelvic wall. Chalo. If it's a TLH and BSO, then in such kind of cases, then adnexa should be removed first. Okay, to facilitate our dissection. चलिए, grasp. मैंने ureter बचेगा. Okay, अच्छा. Hmm. So fine, we are you can appreciate the exact plane where we are working right now. Okay, and hypogastric, can you see? Then जाता हूँ watch this. चल clean कर. स्विच वाला दीजिएगा मैडम, आइए क्या कट करना अपन। पोस्टीरियर वजाइनल वॉल आ गई। चल भाई, that's the rectum. Okay, नहीं थे मुझको कोई कर ऊपर से कहा था मैं नीचे दूँ, नीचे दूँगा। So that plane was wrong. We were going inside the vaginal wall initially. Okay, that's the right plane. Can you see? This is posterior vaginal wall. From here, we were going in a wrong plane. We were going inside the vaginal area. See here? Okay. So now that's the right plane, and nothing is, you know, no problem. Only this, which we will have to take care of. So that's a big plug. Okay, from here it started. Chalo, અહીંયાથી પકડજો. અહીંયા આ સાઈડથી તમે પકડીને જરા કમેન્ટ કરી રાખો. Yes. Okay, ચલો આગળ. બરોબર છે. અહીંયા આ શું છે? ટૂંકમાં ક્યાંય બીજું નથી તો પછી સ્ટીચ મારવાની જરૂર નથી હોતી. એમાં આવું નથી ના સીધું તો નહીં. હવે ક્યાંય બીજું ઇન્વોલ્વમેન્ટ જવું નથી. ફાઇન. શું છે આ બાજુ ફાઇન. ચાલો બ્લેડર. So now we will go with our standard steps for TLH. As she is a case of previous C-section, we will have to take care of the bladder. The time of dissection that will take care of it. Can you see this is window we have got. Right now what we are doing is the central dissection. This we are detaching fibers from its attachment centrally. Okay, that's the central dissection. There are few different technique of doing such kind of dissection. One is central dissection, one is lateral window technique. You should be knowing both because sometimes your one technique may not be helpful. It happens that sometimes you go for the lateral window technique and you will not be able to find any plane, right? Or Sometimes it happens that even in central dissection you will not be able to find vein. Then you will have to go for the lateral dissection. Chal. So now, one thing you should be doing is just see to it, say ureter is going down from here, and there is not at all any involvement. Okay. Let's say if this is puckered, let's say this parametrium is involved. Okay. Then what you have to do is you have to release this roof. Can you see this roof? This you have to release this, huh? To make sure that ureter is not going to get entrapped. Okay. So that is very important. But then in our case, it is not required. Even I'll not go here and take this area out and all these things I'm not going to do. So the bottom line is do whatever is necessary. Okay. Clean kar jaye. Unnecessarily do not try to do or jump here and there. Okay. Like what we did yesterday on Facebook when we did Facebook Live, that surgery where right-sided hypogastric was involved. Nothing. Okay. And you know reason. So whatever is necessary, fine. What is not necessary should not be. Shall opposite. Churak. Now see ureter is very close. Huh? Yeah. नीचे कहूँ અહીંયાથી આને actually ureter is very close here. So what I want is to बस the best point is to go one by one. That means you coagulate, then you cut again antiviral करो. Again you coagulate and you cut. Okay. So what happens that more efficiently you can coagulate. Ureter છે then. Chances of bleeding will reduce. Definitely chances will be there, but then चल વોચ વિશ ટોટલ કેટલા છે અંદર? ચલ ક્લીન કર. મારી બાજુ રાખ. ઓકે બચ્ચો ભાઈ, 1.5 કલાકમાં જ ભાન ભૂલી ગયો છું. This we are preparing ourselves for suturing, huh? And vault. So we even if we do not do this, it is fine. But then at the time of vault suturing and all, we will have to little bit struggle. So better to do it right now. Fine. चल. So right now what we are doing is we are remaining on the top. चल थोड़ा पाछળ લઈ લે. દંડ તક મારજો. બસ. ચલો પોઝિટ દે. અંદર નાખ. ક્લીન કર. અંદર નાખ. કોલ્પોટોમાઇઝર અંદર આવવા દે. આવવા દે. જેમ હતું એમ જ આવવા દે જ્યાં બસ. So we need to find border where we have to remain for dissection, right? If you have colpotomizer, it is good because colpotomizer will guide you. The border where you have to remain. Chal. If you do not have colpotomizer and if you are using, let's say, Miyama screw, okay, from above to cut, then according to your feel of tactile sensation with your instrument, you may decide where to put an incision. Fine. चलो पहला काट ले जो है मुझे NS वो किडनी पे माइनस दीजिए हार्मोनिक बंद कर जाओ भाई कर बैठे चलो हाँ वांधो नहीं हाँ स्पेस गॉज पीस नंबर 1 हाँ एंडोबैग जो सर दिस इज चलो गॉज पीस नंबर 2 and that's गॉज पीस नंबर 3 चलिए काट ले लो फटाफट काट અને પાછા આવો દેને जी कहो so everything is out I think and અને પછી આપી દઈએ we'll review anatomy which is very important part of surgery and then we'll go for the suturing नहीं तो ले लो तुम ले लो આ એક ઓલું છે એટલે આવી ગયું બારે. ચલો ફેક. Now we'll let us see what we have done so far. એક ઓલો બોલ ઇન્ટિગ્રિટી ટેસ્ટ કરી લીધો એ ભૂલજો નહીં છેલ્લે. Fine, this was the ediciolysis. This is IP ligament. This is ureter. નીચે કહો ને ભાઈ. Okay, and seems to be intact. This is hypogastric nerve from here. That's why I did not do anything in this area. Okay, chalo. Opposite. This is pararectal space from this side. Babajithi aao. Pararectal space from this side. Hypogastric nerve. Ureter from here. That's the ureter. Okay. And retroperitoneum, external iliac vein, artery, internal iliac, uterine, આ બાજુ ઉપર આવો. Yeah, this is IP. Okay. So everything seems good. Fine. ચલો suturing કરીને પછી ઓલું રેક્ટલ ઇન્ટિગ્રિટીનું જરાક જોડાઈ લીધું. બાકી કાંઈ અંદર બાકી નથી રહેતું. ચલો, થેન્ક યુ.